difficult to make those conclusions, only because we don't have the same patients. A lot of the patients that got pre-surgical therapy, 10, 15 years ago were patients that presented with poor risk disease. Those patients were treated, and then the patients who did well out of that group, those patients were offered surgery. What we don't have is the denominator of the patients who did not do well out of that group, who were never offered surgery. So I think it works very well as an approach for patients who are at high risk, and high risk meaning that those patients are going to do poorly, from an overall survival standpoint. I think that preoperative or pre-surgical therapy is a very viable approach. But if you come into our clinic and you have a good performance status, you're a young, healthy patient, and you have maybe one side of metastatic disease, some of these patients do very well with an upfront approach. And they're really different patients. And that's one of the things that really has to be pointed out in these cohorts. Surgically collected cohorts are different because these patients all have synchronous metastatic disease. So they all had metastatic disease at the time they came in. And we know that those patients do much worse than a patient that, for example, has a nephrectomy and 5 years later he develops metastasis. Those patients do much better. So in that way, there's a negative bias to the surgical cohorts. But we also know that the surgical cohorts are selected for patients with a better performance status, patients who can tolerate surgery for the most part, and probably have more favorable tumor biology, less metastatic disease that we can't remove at the time of surgery. So there's both positive and negative biases, but the surgical cohorts are just different. And you can see that both in the outcomes and the baseline demographics. I think that it's, there's a lot of difficulties with randomizing surgical patients, right? When you come in and you think that something's going to benefit you, like surgery, and you're signing up for something that has risks, a lot of times people don't want to be randomized to whether or not they can have that. That's one of the reasons why, like, the Carmina trial was not done in the United States, was because people thought that our population was not going to enroll in that type of study. It's one of the reasons why that study took a very long time and was actually closed due to poor patient accrual, never met its futility analyses, and was difficult to analyze at the end of the day, because the patients that were in there, a lot of surgeons looked at that trial and said, these patients are not the patients we operate on. If you look back at the two initial randomized trials, and these were 2001 when they were published, but the reason why that's important is, from a scientific standpoint, those patients at that time, there were no other options for treatment. So it was basically interferon alpha or surgery plus interferon alpha. And in the patients that got surgery, their overall survival doubled. Now, interferon alpha didn't work better in those patients. You couldn't see an objective response that was better in the patients. The patients just lived longer. And so in some ways, scientifically, that's the best evidence you're going to get. Nowadays, like in the Carmina trial, when patients failed sunitinib, which was the initial thing, they got many different second and third lines of chemotherapy or systemic therapy. So it's harder to study the absolute benefit. And I agree with you. It's the data doesn't show that there is, with modern therapies, doesn't absolutely show that there's a benefit or not a benefit. We just haven't done the studies in the patients with favorable or intermediate risk. And those are really the patients we should do the studies in, because those are the patients we operate on primarily. The other big thing that's not discussed is patients seem to get a symptomatic benefit. And this is something we've been studying more recently in the past, 2 to 3 years, trying to use validated quality of life metrics. And so patients get a symptomatic benefit from surgery that is impressive. We've observed that for many years, but we haven't really used ways to objectively measure that. And then so if you're a patient and you're coming in and you're bleeding and you're not feeling well and you've lost a lot of weight and you have no energy, and you can objectively say, well, if you have surgery, a lot of those symptoms will get better faster, then maybe that makes sense for you. I think that people are trying to figure out the best way for patients to improve patients' outcomes. I think that it's a very diligent effort, I think, but it's difficult to study this because, again, doing surgical research, patients don't want to be randomized to get surgery or not for the most part, and so it's difficult to just say whether or not it benefits every patient.